Good morning, everybody. Welcome to day 2 of the Nurses in Assisted Living. We will kick off in a couple minutes, about 9:55, just to do some housekeeping. So we'll talk to you guys in a couple of minutes. Good morning, everybody. Welcome back. This is exciting day 2. Let us know in the comments what you guys thought of day 1. Were there speakers that you thought were extraordinary? Did you learn a lot? This is a yearly event, so what you'd like to see next year. We're also going to go to more virtual format for like quarterly trainings. So as nurses, if there's some kind of quarterly training you'd like to see, please let us know. Also, the Assisted Living Nurses Association will come back virtually in January. It'll be January 19th. And all these dates will be on our new website when the website's posted. So, and it'll be at 8:30 on January 19th. And some of the other committees we have while we're sitting here chatting is we have the Memory Care Committee, which is January 13th, 9 a.m. Poly Policy Committee and / All Text Committee is January 14th. That starts at 2 p.m. That's one of our later meetings because of our lobbyist joins us for that meeting, and that's when our schedule clears during session. And we also have workforce development on January 27th at 9 a.m. and we're working on disaster prep. We have to get with the chair, Khalib, I'm going to avoid his last name, with Titan Restoration. Also, on the website, y'all have a profile page that if you go to the members and you click on your page, you'll see that you have this beautiful profile page. If you have not set it up, please set it up, because with the new website, there is going to be a button to click that will take people, and it's very prominent. It's on our top, on our banner, and it's very prominent saying, if you're looking for senior living, click on this button. So you really want to make sure that you have a good profile up there. I think we set it up so you have to look at the different blocks and then just send it over to us when you have it, and we will get it going from there. I don't know, Mariah, it doesn't give me the option to make you a co-host. So, and I don't know if I'm a host. Are you already there? Okay. And I don't know if Josh is on. So Josh, I don't know if you're here, but I'm going to turn it over to Mariah Ortiz. She has some updates as well. Mariah, the floor is yours.
Thanks, Karen. Good morning, everyone. I just wanted to do a quick reminder. We do not have exhibitors specifically at our conference this year for the fall, but we do have all of our exhibitor profiles from our August conference still on our page. So if you guys want to go check that out, if you have just want to look at any of our exhibitors, all of their information, their websites, their contact information should be on the left side when you guys enter the virtual platform. And then if you scroll down, you'll see the exhibitors tab. So make sure you guys definitely still go look at them. And then I want to say a quick thank you to all of our sponsors. We have Hospice of the West, Live Generation Senior Living, Corman Healthcare, Titan Restoration, Hospice of the Valley, Celebes Extended Care Pharmacy, Mercy Care, and then Belmont Village Senior Living in Scottsdale. Also, some people that it's really hard for us to give a huge thank you to when it's virtual is our Educational Events Committee. Usually when we're in person, you guys see them running around and helping us so much, and it's obviously way different now since they're not here with us, but they still do the same amount of work for us in all of our meetings. They really are the ones that get our speakers and tell us suggestions and confirm speakers that they want. I mean, they're really in charge of building this conference for us. We just kind of take what they give us and put it together. So first I'd like to thank Jane Keys, who is our Educational Events Committee Chair from Sun City Caregivers, Christy Mitchell from Hospice of the West, Cynthia Cannert from Pacific Mobile Diagnostics, Mashawn Jablonski from Dispatch Health, Tracy Hodges from Vi at Greyhawk, Millie Okeson, she is our consultant now, Kay Baker from Glencroft Center for Moderate Aging, Mary Cleansing from Corman Healthcare, and then Belinda Ratter from Live Generation Senior Living. Thank you guys all. If you guys are on here, thank you. You guys do an amazing job for us always, and we always have a bunch of fun. It's really we have a great time together, so it's a great committee for sure. But that is all for now, and we have Josh Allen coming up, and then we have Hospice of the Valley sponsoring this session. So I will hand it over to Hospice of the Valley for the speaker introduction.
Hi, everyone. I'm Samantha, and I'm the community liaison of Hospice of the Valley. I'm so excited to introduce you to our first speaker of the day, who is Josh Allen. Josh Allen is a registered nurse and a principal at Allen Flores Consulting Group. He has over 25 years of experience in senior living, including executive leadership, where he has overseen health services, staff development, recruiting, and regulatory compliance. Josh consults on risk management and legal cases, including testifying as an expert on assisted living standards of care. Josh is certified in assisted living nursing by the American Assisted Living Nurses Association. He also serves on the board of directors of the California Assisted Living Association and is a past board chair of the Center for Excellence in Assisted Living. So thank you again for having us, Hospice of the Valley, and I'll hand it over to Josh Allen.
Thanks, Samantha. Good morning, everybody. Appreciate being here. Thanks to Karen for the invite. I'm still not quite used to these virtual conferences. I used to feel like I went to way too many conferences, and now I miss going to conferences. So I'm hoping next year, some way, somehow, we're all going to be back together again in one place. But be it as it may. For now, we make do, right? Like everybody else is with everything COVID. When I was talking with Karen about this session, and she said infection control, I thought, you got to be kidding me. People couldn't possibly want to hear about infection control again, during COVID. But I think, let me share my screen here. I think, it as much as it pains us to maybe think about it sometimes, it's important that we stay tuned into these basics, because it really is kind of the basics of infection control that are going to make and break it, not only during COVID, but when you're dealing with all of the other, fun infectious diseases we see from time to time, whether that's noro or flu outbreaks or whatever it might be. So there, in our session, I think there's a few things we'll try to cover. I first want to remind you, and this is hopefully stating the obvious, that when it comes to infection control, we always want to make sure we're working off of the latest guidelines from the experts. And that starts with the CDC. They're obviously nationally, they're the experts on infectious diseases, on how to prevent those infectious diseases. So we always want to make sure we go back to the CDC to make sure we're implementing their latest recommendations. And obviously right now, our whole world is all about COVID. And the CDC really has been incredible at updating and providing information on COVID, but they have a wealth of information on really any infectious disease you've ever heard of, and probably many you've never heard of. So whether it's the flu or noro, or even things like scabies, whatever it is, you're trying to look at policies and procedures, best practices. It's a really great resource. So if you're not already intimately familiar with the CDC's website, it's definitely a place you want to check out, because they really do have a lot of great information. They have even a lot of training materials. For example, on seasonal flu, they have great stuff on training staff on seasonal flu, and they have it in like a dozen different languages. So if you need something in Spanish or even Tagalog or whatever it might be, it's all there and available and free, and just a really, really great resource. So I always like to mention that when we're talking infection control. So what I want to try and cover in our short time together are sort of these 5 key points, and then we can certainly branch out from there if you guys have questions. And I would encourage you, by the way, ask questions. I'll keep an eye on the chat window, or jump in however you want. Love getting questions, makes it much more interesting than just listening to me talk for an hour. We'll start with standard precautions. We'll talk a little bit about the different transmission-based precautions, as well as personal protective equipment, reporting, and staff training. And obviously, while this session isn't just specifically about COVID, more broad discussion of infection control, it would be it's the elephant in the room not to mention COVID when we're talking infection control. And I think, I don't know about you guys, but I know myself, I've learned a lot about our infection control capabilities and preparation because of COVID. There's no time in any of our memories that we've been tested the way we have with COVID. And I think we've learned a lot. And at this point, 8 months into it, we've hopefully found solutions to a lot of these issues. But it really, I think, forced us to step back and really identify how prepared are we. In the past, we all dealt with things from time to time, mostly flu and noro. And every now and then you'd have a legit outbreak, and it would shut your community down for a couple of days. But then that would, for the most part, that would be the end of it. You'd kind of move on. And it never really pushed us in quite the way that COVID has. For example, one of the things we've really identified in many communities is real challenges with hand hygiene, which is kind of astonishing when you think about it. It's the most fundamental component of infection control. You wash your hands. We say it all the time: wash your hands, perform hand hygiene. But when you look at a lot of senior living communities, the way they're designed and the way facilities are set up, we don't always have great access to hand hygiene. There's very rarely are there hand hygiene stations set up throughout the community, at least certainly not in the past. So very often, if our staff were performing hand hygiene, they were doing one of 2 things. They either had hand sanitizer in their pocket, or they would use the resident's bathroom in their apartment to wash their hands. And that creates a lot of issues. If you think about using the resident's bathroom, using their sink to wash your hands, the first question that comes up is, do they have appropriate disposable paper towels? Most resident bathrooms don't. They have their
and then Janetta Works, we keep our tracking there, and then we turn in a line list.
They have their nice, decorative, bathroom towels like we all have at home. They have those hanging next to their sink, but they don't really have disposable paper towels. So your staff wash their hands, and now how do they dry them? It's also an issue if this is a resident who is on quarantine or isolation, because you're performing hand hygiene in their apartment, and then you're having to grab their apartment door handle to leave. You really would need to perform hand hygiene again. Keeping the hand sanitizer in your pocket, it's maybe not the worst thing in the world, but it's also not the best thing in the world. If you're reaching into that pocket to get to the hand sanitizer, and then putting it back in your pocket, there's all sorts of opportunities for cross-contamination of your hands. So we've talked to, one of the first things a lot of providers kind of went through back in March and April when we were first facing COVID in the US was really looking at the availability of hand hygiene, setting up hand hygiene stations, mounting the hand sanitizer, throughout the community. It doesn't do us any good to tell our staff to perform hand hygiene if in reality they don't have great access to it. We also, I think, learned a lot about personal protective equipment. For most of our existence, the only personal protective equipment we would really utilize on a regular basis were gloves. And then from time to time, we might need some surgical masks, we might need gowns, but in our world, that was actually pretty uncommon. We were mostly dealing with gloves. And so now we've had to look at, where do we store personal protective equipment? How do we make sure staff have access to it? What type of personal protective equipment do we need? And again, at this point in the pandemic, hopefully we're beyond that challenge and we figured all that out, but it certainly has been a challenge for us. Fit testing. This is one of the latest topics people are really being faced with as OSHA around the country, different state OSHA agencies are really kind of putting down the hammer on fit testing, which we can get into more later if there's questions about it, but that's the process where you make sure that an employee is able to appropriately wear an N95 respirator and that it fits correctly. And that's a bit of a process to complete. Something that in our world, we never did. I've been senior living for 25 years, maybe even a little bit longer now. And we never had to think about fit testing in the past. It just wasn't really a part of our world. And now all of a sudden, N95 respirators have become commonplace, and we're having to figure out how to get through fit testing. But hopefully, above all, what I think we've learned from COVID is that as providers, we are really capable of more than we thought. If you think about the things that we've had to implement in response to COVID, pre-COVID, we would have thought this was impossible. I mean, think about things like not doing tours. I remember I've had many arguments with sales and marketing directors over my career during flu outbreaks when we wanted them to stop tours for just a couple days. And now we have communities that have suspended tours for months and months and months, and they've found ways to do it virtually to connect with prospects more creatively than just the standard tour. You look at the use of PPE, having staff running around with masks on all the time. Again, pre-COVID, we never would have dreamed of doing that for the amount of time we have. Even during flu outbreaks, we still typically in most communities had relatively limited use of masks. So we've overcome a lot. Hopefully it's really prepared us in ways that we never thought we would be prepared before. And honestly, I think it's going to make a lot of other infectious disease issues seem like a piece of cake compared to what we've gone through with COVID. So when we talk about infection control basics, I think it's a good reminder. And I know most of you in this session are nurses, but not everybody here is a nurse. So I think it's important to understand what we often refer to as the chain of infection. This is basically the elements that you have to have in place in order for an infection to occur, and in order for that infection to be transmitted from one person to another. And when we look at our infection control processes, our policies and procedures, the practices we want to implement, they are designed to break this chain. And typically they are designed to break the chain in multiple places. We don't just focus on one thing, we address all of these different steps in the so-called chain of infection. So obviously the first thing you need for an infection to occur is you need the infectious agent, right? You need the virus, the bacteria, the fungus, whatever it is, you need that infectious organism present. And so obviously the first thing we all think of right now would be the SARS-2 coronavirus. It's a good example. You then need a reservoir. And a reservoir could be lots of things. A reservoir is basically a place where that organism can safely survive and multiply, okay? So it needs a place to live. And for most infectious agents, the ideal place for it to live is in people. You know, that's why it's causing disease. We make a good reservoir for that organism. But they can also, depending on the organism, they can live in other places. They can live on surfaces. They can live on doorknobs, toilet seats, sometimes live in animals, depending on the agent that we're talking about. That infectious agent in the next step then needs what we refer to as a portal of exit. It needs a way out. So if we keep using the SARS-2 coronavirus as an example, the human body is essentially the reservoir. It needs a way to get out of my body. And as you guys all know, SARS-2 coronavirus is a respiratory virus. So the way it gets out is through my respiratory system. When I cough, when I breathe, when I speak, when I sneeze, comes out in those respiratory droplets. Other infectious agents may have different portals of exit depending on which one we're talking about. Let's use another well-known example, HIV. HIV, as I'm sure you all know, is a blood-borne pathogen. So the human body is the reservoir, but it lives in the blood. So its portal of exit would be through blood and other body fluids, particularly those that could contain blood. That's how it's going to get out of the body. It then needs to be spread to that next susceptible host. It needs a mode of transmission. And again, that varies based on the infectious agent. We'll keep using our two examples. We know that SARS-2 coronavirus, the mode of transmission is primarily respiratory droplets being spread from person to person. In the case of HIV, it would be contact with those infected blood or body fluids by the next host. Most infectious agents will have those primary modes of transmission. So SARS-2 coronavirus is not spread in the blood. HIV is not spread in, when someone coughs, breathes, or sneezes. It's not spread through the respiratory route. The agent then needs a way to get in. It needs a portal of entry. So for example, if you have SARS-2 coronavirus just sitting on your skin, it's not going to infect your body. Okay? It doesn't go through your skin to cause that infection. It needs access to your respiratory system and the mucous membranes in that respiratory system. So in the case of SARS-2 coronavirus, it needs to get into your mouth, your nose, or possibly your eyes, because you have mucous membranes there. It needs that portal of entry into the body. In the case of HIV being a blood-borne pathogen, you would need to have either a break in your skin. So if you had a cut and that cut got some infected blood in it, you could then become infected. Of course, we know HIV can also be sexually transmitted, and it could also transmit through mucous membranes if those mucous membranes came in contact with the infected blood. The last element in this chain, and this is, I think, a really important point, is you need a susceptible host. Okay, not everyone who comes in contact with a infectious agent is going to become infected. Some people come in contact and they don't get infected. Their immune system responds, it kills all of the infectious agent, and they don't themselves become infected. And again, depending on the disease or the organism, how susceptible someone has to be varies. We know, for example, with COVID-19, we know that the SARS-2 coronavirus is highly transmissible, and people are very susceptible to infection. Now, not everyone is as susceptible to disease, which is a sidetrack we probably don't need to get into today, but you can be infected with an organism and not get sick. In fact, we know that around half of people that get infected with SARS-2 coronavirus don't actually get sick. They don't ever get any symptoms. Okay. So our efforts in infection, if you really understand and think about this chain of infection, everything you need to do to break it, I think, just starts to make sense, right? We need to focus our efforts at controlling infection, and I'm not just talking COVID. I need you to think beyond COVID for today, is all about breaking that chain. So we want to try to break it in as many places as possible. So we want to get rid of the infectious agents. We want to keep them out. And that's our cleaning and disinfection. That's our screening, like we're doing for COVID. We want to make sure we keep those things out. For example, TB testing, right? We routinely do TB testing in our communities, or not necessarily in the community, but with our residents and employees. And part of that is we want to keep TB out of the building. We don't ever want it to get in. If you can get rid of the infectious agent, the rest of this chain is broken. We also want to try to reduce reservoirs. That's why we keep our environment clean and disinfected. That's also why we do things like getting our appropriate vaccinations. That's why you should get your flu vaccine every year. That's why you should get your COVID vaccine when it's available pretty soon here, because you want to keep yourself from becoming the reservoir. We control portals of exit. That's why everyone right now is wearing a mask, right? You want to control the exit in case you were infected with the virus that causes COVID. So when we talk about our infection control measures, there's basically two broad categories, okay? There are standard precautions and there are transmission-based precautions. And it's, I think, really important that we have a good fundamental understanding of both. We have policies and procedures in place that address both, and we educate all of our team members in how to implement both sets of precautions. Let's start by talking about what is really the basis of infection control in any care setting: standard precautions. Standard precautions used to be known as universal precautions. If you've been a nurse for long enough, or you've been in the business long enough, that's a term you've probably heard before. We really started, really universal precautions were formed and developed when HIV first started to appear in the US. That's where we began to develop the concept of universal precautions. Over the years, some things got tweaked and sort of massaged in it, and the CDC eventually changed the name to standard precautions. And that's the term we've been using for many years now, well over a decade, probably longer. Probably the most important thing to remember about standard precautions is that it is used for all resident care. Standard precautions are used all the time. That's why we call them standard precautions. They should be our standard procedures. No matter what the situation is, we implement standard precautions. The basic idea here really is that for a lot of infectious diseases, particularly many of the bloodborne pathogens or diseases, things like HIV and hepatitis, a person can be infected and they might not know it, and we might not know it. So we basically operate under the assumption that, to put it kind of bluntly, everyone has everything. Whether you're a resident or a coworker or whoever you are, we assume that everybody could be carrying everything, and we implement these standard precautions to prevent it. From time to time, we will, I'll hear things from staff that make me worried. Though, for example, I was on the phone not long ago with a community who had a resident who had moved in who was HIV positive. And the nurse in the community was saying, should I notify all my staff that this person's HIV positive? And my first question was, well, why do you feel like you need to notify your staff? And her response was, they'll be more careful. And that should be a huge red flag. Because if they're going to somehow be more careful, that means they're not following standard precautions every day. Because if they were following standard precautions every day, they would be assuming that every resident in the community was HIV positive, and they would be taking the appropriate steps to prevent it. So again, you've really got to ingrain in your team, train them, retrain them, discuss it routinely, that these are the things we do all the time with everybody. The key elements of standard precautions include hand hygiene, obviously the use of personal protective equipment, respiratory hygiene, cleaning and disinfection practices, the handling of laundry, and sharps. So let's go through a few of these and kind of hit some of the key points. We already kind of touched on this a little bit earlier, the importance of hand hygiene. We have two options for hand hygiene. We can use good old-fashioned soap and water, or we can use alcohol-based hand sanitizer. These are the recommendations from the CDC on when you would use one or the other. The one thing I want to emphasize is you can always use soap and water, okay? It is always an acceptable option for performing hand hygiene. So if you don't have access to alcohol-based hand sanitizer, or some people's skin is sensitive to repeated use of alcohol-based hand sanitizers, you can always use soap and water. But there are situations where alcohol-based hand sanitizers really aren't enough and you need to use soap and water. So let's actually start with that list because it's a little bit shorter. You really need to use soap and water under kind of two primary situations. One is if the hands are visibly soiled, okay? Now, hopefully that's not going to happen because you were using personal protective equipment, but if it somehow happened that your hands were visibly soiled, there was junk on your hands, you would need to remove it with soap and water as part of, and perform hand hygiene that way. Let's say you had some blood on your hands, for example. Again, should never happen because you're using your gloves, but if you got blood on your hands and you just used an alcohol-based hand sanitizer, all you really do is rubbing that blood around your hands. And so whatever was in the blood may not get killed. So we use the soap and water to physically remove that blood from our hands. And then we do our hand washing, as you know, for at least 20 seconds. And we do that to kill whatever might have been left behind. You also need to use soap and water for hand hygiene if you're caring for someone with known or suspected infectious diarrhea. It could be, for example, C. diff. One of the reasons we do that is because of spores. Things like C. diff have spores or form spores, which is sort of a protective shell, if you will, around the bacteria, allows it to survive much longer, and means that it may not necessarily be killed by just the use of alcohol-based hand sanitizer. So in those situations, it needs to be soap and water. And again, that's one of the things you need to look at in your community is what sort of access do we have to soap and water for hand hygiene if and when we need it? Are there hand washing stations? If someone's going to wash their hands in the resident's apartment, are there disposable paper towels? Those things we were kind of talking through earlier. Otherwise, outside of those scenarios, the CDC does actually suggest that alcohol-based hand sanitizer be your primary form of hand hygiene. And then of course you do it in all these scenarios that I'm quite sure you're familiar with. Before and after resident care, before performing any aseptic task, which not many of us would be doing in assisted living, but it could include in placing a catheter, for example. Moving from a soiled body part to a clean body part. For example, if you assisted a resident with incontinence care and now you're going to help them, brush their teeth or do their hair, you should obviously wash your hands. After any contact with blood, body fluids, or contaminated surfaces, and immediately after removing gloves. And that's one that we really want to emphasize to our staff. You need to perform hand hygiene after you remove personal protective equipment. Sometimes people either don't understand the risk and they think, well, I had this equipment on, it protected me, I don't need to wash my hands. Or frankly, we just get into bad habits and we get in a hurry, or we get a little bit lazy and we remove personal protective equipment and then just go on about our next task without performing hand hygiene. Respiratory hygiene or cough etiquette is also a part of standard precautions. Again, right now with COVID, this is stuff we're all highly, highly sensitive to. But even outside of COVID, and when we eventually get beyond COVID, someday, hopefully sooner rather than later, we want to make sure that there's tissues available, there's no-touch receptacles available. Again, we want to make sure people have access to hand hygiene. And now we're not just talking staff, we're talking visitors, we're talking residents, we're talking, third parties that may be in the community. Again, right now, a lot of those folks aren't in the community, but when we get back to more normal times, we want to make sure all of those folks also have access to tissues, no-touch receptacles, and the ability to perform hand hygiene. We want to educate people to cover their mouth and nose with a tissue when they cough or sneeze, then dispose of it in the nearest receptacle and perform hand hygiene. Certainly cleaning and disinfection is a key part of, again, breaking that chain, right? That's going to help us to eliminate the agent. That's going to help us to reduce the risk of reservoirs. So it's something that should be part of our normal routine practices. One of the things I'm really find myself constantly reminding people is that cleaning and disinfection are not the same thing. They're actually two different steps. And the simplest way to think of it is you have to clean something before you can disinfect it. Cleaning really just refers to removing any matter, any debris from the surface. And for cleaning, you can just use soap and water. You can use anything, whatever you want, really doesn't matter. To disinfect, what you're trying to do is actually kill any germs that may be on that surface. So, for example, if you had, let's just use an easy one, if you have blood on a bathroom counter, resident custom self-shaving, and now there's blood on their bathroom counter. We don't want to just go in there with bleach and wipe it all around, because similar to what we talked about earlier with hand washing, at that point, you've just moved stuff all over the place. You haven't necessarily removed it. So the first thing you have to do is just clean up that blood. And that could be with anything. It could just be with water. It could be with warm water and a paper towel. It could literally be anything. You want to remove all of the visible blood from the countertop. Then we come back and disinfect it. When we disinfect it, we want to make sure that, number one, we're using an EPA registered disinfectant. And there's actually a very long list of options. It does include good old-fashioned bleach that you obviously would dilute with water, but there are a variety of EPA registered disinfectants to choose from. They have a website you can go to and see that long list. And again, I would imagine during COVID times, that's a list you've referred to more than once as you were finding disinfectants that are effective against the SARS-2 coronavirus. When you disinfect, you want to follow the manufacturer's instructions for exposure time. As a general rule of thumb, it doesn't necessarily apply to all disinfectants, so you want to verify, but as a general rule of thumb, after you clean, you'll apply the disinfectant like with a spray bottle, and then you let it sit. You don't do what a lot of us probably do at home, frankly, which is immediately wipe it up. If you immediately wipe it up, you've removed it. You haven't given it time to kill whatever was on that surface. Typically what that looks like is you apply it with a spray bottle and then you let it air dry. You let it evaporate. And the amount of time it takes to air dry is enough exposure time. And actually the evaporation process itself can help to kill things. And then that surface has been disinfected. So again, for a lot of people, that process is, a little more complicated than maybe they ever thought about it. Again, a lot of us at home, we have very poor cleaning and disinfection practices. We just go in with our 409 or whatever, and we just start spraying and wiping everything up. We really want to make sure that in the community, our housekeeping or whoever is responsible for this, they clean the surface, then they disinfect the surface. It's two different steps. Of course, make sure those disinfectants are stored properly. They generally are quite toxic, particularly if they were to get in the hands of a resident, such as a resident with dementia or other cognitive impairments. So make sure those things are locked away. And when staff are performing this, they should, of course, use appropriate personal protective equipment. Along those same lines, standard precautions includes appropriate handling of textiles and laundry. And this is probably the same folks in your community who are responsible for cleaning and disinfection are probably also responsible for textiles and laundry. We want to make sure, for example, that we don't shake linens. You think of how you make your bed at home. You stand at one end of the bed and you flip the sheet in the air and it kind of comes settling back down. That is not how we should perform bed making in the community. When you flip that sheet or that blanket in the air, if there were any germs, any organisms on it, they're all now thrown up in the air for people to be exposed to or possibly breathe in. We want to make sure when we're handling soiled laundry that we don't hold it against the body. So we don't, scoop all the sheets off the bed and then hug it against our chest as we carry it off to the washing machine. We want to make sure we hold things away from the body so that we're not contaminating our uniform. We should wear appropriate personal protective equipment, which generally for this would mean gloves. If the linens are particularly soiled, if a resident, for instance, was incontinent or is suffering from diarrhea, then they may also need a gown for an additional layer of protection. And of course, soiled linens should be transported in dedicated containers. We should not have staff walking down the hallway handling soiled laundry. For one thing, it's gross. It's probably not something your residents would appreciate, or the families for that matter, once they're back in the community. And it's much more likely that you're going to expose someone or something to that soiled laundry if we're just carrying it around. So we should have dedicated soiled laundry bins or containers. Along sort of similar lines, sharps are a very important part of standard precautions, proper handling of sharps. You should have a policy that requires safety needles or syringes as well as lancets. These are the syringes with a safety device that sort of retracts back down and reduces the risk of a needle stick injury. I would highly recommend that be mandatory in your community, including if residents are purchasing their own supplies. I would require that they use safety needles, safety syringes, safety lancets. I would say in my career, I haven't seen a ton of sharps injuries, but I've seen my fair share. And as I think back on them, the overwhelming majority of sharps injuries happened from staff accidentally coming in contact with resident sharps. In other words, it wasn't the staff person giving an injection and then sticking themselves. That does happen. But more often than not, it's a resident who was self-injecting or maybe doing their own, glucometer, and they didn't handle the sharp properly, and a staff member inadvertently got stuck by it. I've seen things like needles and syringes in the bed linens. That's one we've seen several times. When you think again, the safe handling of linens, make sure there aren't any sharps in there. I know it sounds kind of crazy, but it's surprising how often that's happened. Residents throwing things in just their regular trash can, and staff go to empty the trash, and they maybe grab the trash bag and they get stuck to the side of the trash bag. Overfilling sharps containers. One of the first sharps injuries I ever ran into as a nurse was a sharps container in an apartment that had just literally overfilled. The resident just kept shoving things in it. It was never emptied or replaced. A sharps, a syringe had fallen out of the container into the plant that happened to be sitting up against the wall in that same area. A member of the housekeeping staff went into, they were watering the plant, or what they were doing. They were doing something with the plant, and they got stuck. They, of course, didn't think there was going to be a sharp sitting in someone's house plant. So again, it's sometimes the seemingly simplest things, but more often than not, in my experience, it's the resident mishandling their sharps more so than it is our staff. Make sure we have sharps containers, make sure they're readily available. So if you have residents who are independent with their injections or their blood sugars, they need a sharps container. So that may mean having one in their apartment, or if you're bringing them the supplies when they do their injection, that should include bringing a sharps container. A lot of times we have them attached to the side of the med cart or something like that. And again, make sure we empty and replace those containers as often as necessary. They should not be allowed to overfill. So again, all of that is standard precautions. Those are the things that we are doing all the time, every day, no matter what. In addition to standard precautions, our staff need to be familiar with what the CDC refers to as transmission-based precautions. Transmission-based precautions would generally include contact precautions, droplet precautions, and airborne precautions. And which set of precautions you use depends on the pathogen or the organism that we're dealing with. Again, right now in our fun COVID world, droplet and contact precautions are something we've all become quite familiar with. They are essentially our day-to-day, part of our day-to-day life as we prevent and deal with COVID. Airborne precautions is something we generally would not implement in an assisted living setting. True airborne precautions require interventions that we are just not equipped for. Special isolation rooms, special ventilation in those rooms. This is for stuff like tuberculosis. This is just beyond what we would be doing in an assisted living setting. But we absolutely should be prepared to do both contact and droplet precautions. Contact precautions, so the point here is the organism could be spread through direct contact. So you think of norovirus would be a good example. C. diff would be another example. COVID is an example that if you came in contact with the organism, and then depending on which one we're talking about, if you brought it to your eyes, nose, or mouth, you could then become infected. So the steps to implement contact precautions starts with number one, appropriate resident placement. If a resident requires contact precautions, they should generally be in their own apartment. So again, as much as I can't help myself to keep referring to COVID, if you have a COVID suspected or COVID positive resident, they should not be in a shared apartment. Now, the truth of the matter is, I'm sure many of you, like myself, sometimes you have residents who are spouses or partners, and they are going to choose not to separate. And that's something that you'll have to work through. And I would also emphasize document. But generally speaking, if a resident requires contact precautions, they should be in a private apartment. The personal protective equipment required for just contact precautions is gloves and a gown. We want to limit resident movement, so we want them to try and stay in that apartment. We want them to avoid moving around the community or coming in and out of the apartment. We want to have our isolation in place. Any care equipment we're using should either be disposable or dedicated to that resident. So you think of something like a blood pressure cuff. You wouldn't want to take a blood pressure cuff, use it with that resident who's on contact isolation and then use it with another resident unless it had been appropriately cleaned and disinfected. Droplet precautions are where we are trying to control organisms that are spread through those respiratory droplets. So again, obviously COVID is a great example of that. Influenza is another very good example of that. Really, there's a lot of similarities between droplet and contact precautions. The big difference with droplet precautions is the use of masks. So we should have a mask on the resident for source control. And of course, our staff should be wearing a mask. Now, one of the things that's interesting about COVID, where it starts to kind of fall into almost its own category, is we know, of course, when a resident has known or suspected COVID, our staff are not just wearing a surgical mask, they're wearing an N95 respirator, which is typically more than what is required for just droplet precautions. But obviously, it's the current recommendation from the CDC. A key part of implementing all of this, whether it's standard or transmission-based precautions, is appropriate personal protective equipment. And I know we have about 5 minutes left, so I'll try and go through this fairly quickly because I want to make sure we talk about reporting and training. But a few things to keep in mind with PPE. Generally, the PPE, of course, should be donned before resident contact, typically before entering the resident's apartment. So you think of a resident who's under contact or droplet precautions, a resident under COVID isolation, for example, we're going to have PPE set up outside the resident's apartment so that we can don that PPE and then go into the apartment and perform whatever care was necessary. We want to be careful that when someone's wearing PPE, they should still handle things carefully to avoid as much contamination as possible. In other words, you're not wearing a suit of armor. So you still want to generally try to prevent the PPE from becoming soiled. You think about, during incontinence care or maybe while assisting with a shower. Those are probably the two best examples. You'd still want to just move and use your hands and arms in such a way that you try to keep the PPE as clean as you possibly can. We want to make sure that people keep their hands away from their face. Again, even with the PPE on, if those, as soon as we put those gloves on and we start providing care, those gloves are now considered contaminated. We don't want to touch them to our face. Remember, it's the eyes, nose, and mouth that have mucous membranes that can allow a lot of different pathogens in, including COVID. You generally want to work from clean to dirty. So you think, for example, of assisting a resident with a shower, you would want to generally work from the cleanest body parts to the most soiled body parts if you can. Otherwise, you may need to perform hand hygiene and even change gloves in between. Still try to limit the surfaces you're touching. And of course, we want to make sure people know to change their PPE anytime it is torn or damaged, or if it becomes heavily contaminated. When staff are using gowns, I think a few things to keep in mind is, number one, we want to make sure they have the right size on. It needs to really cover at least the front of their uniform. If the gown is too small, they may need to wear one that comes on from behind, and then they put one to come on from the front to give them the total coverage that is needed when using a gown. Right now, things have gotten better, but gowns are still very often in short supply. So my guess is a lot of you are using extended use of gowns, possibly reuse of gowns, although that should really be in when you have a true shortage and just simply don't have enough for people to change them. Of course, you guys know the drills with masks. I don't think I need to say much about this at this point. We want to make sure people are wearing their mask correctly. I think if we all had $1 for every time we've seen a mask sitting below someone's nose, we would all be independently wealthy, right? I mean, people have bad habits with how they wear their masks. They need to be from below the chin to above the nose, and they need to cover around the sides of the face. Eye protection, whether it's goggles or face shields, again, this is generally only necessary for obviously COVID or people who are otherwise on droplet precautions. You would also wear goggles or face shields if there was ever a time you would anticipate splashes or sprays of body fluid. That's pretty rare in the assisted living setting. We can put eye protection under extended use and reuse in accordance with the CDC guidelines, but we need to make sure they are properly cleaned and disinfected between uses. Staff need to be educated on the proper sequence for donning and removing PPE. As a general rule, this is the sequence when donning PPE. You would put the gown on, then the mask, then your eye protection, and last, finally, your gloves. When removing PPE, the general recommendation would be remove the gloves first, then eye protection, gown, and mask. And a lot of people, that's not their first thought. They think, well, I want to remove my gloves last because that way my hands are protected. The problem with that, if you remove them last, your contaminated gloves are now touching all different parts of your body as you take everything else off. So if you've taken off your eye protection, taken off a mask, taking off a gown, you're touching these different parts of your body with contaminated gloves. So rather, you remove the gloves, then as you remove the rest of the PPE, you do it in a way that you try to avoid touching the parts that may have been contaminated. So for example, the eye protection, you would just grab from above the ears. The mask, you would grab from the back of the ear loops. The gown, you would untie from the back and then pull it off of the body rather than touching the front of it. And then of course you would perform hand hygiene. All right, let's talk real quick about reporting and training, and then I am just about out of time. When it comes to reporting, honestly, we don't need to overcomplicate this. The main thing I want to emphasize is when we're dealing with infectious conditions, and again, I know right now we're so fixated on COVID, but this would apply to any of these other scenarios, flu, noro, C. diff, whatever. We always want to be transparent in our reporting. So we want to make sure we are reporting to responsible parties. We want to make sure we are reporting to the resident's physician or primary care provider. In Arizona, you don't as often have to report these things to state licensing, although with COVID, that's a different answer. And lastly, your health department. If you had to say there's one good thing that came out of COVID, I think that we've gotten much more aligned with our health departments. Now, it doesn't mean we don't ever disagree. We do sometimes maybe see things a little bit differently. But similar to what I was saying earlier about the CDC, the health department is a great resource to us with the expertise on infectious diseases. So when we're making decisions about testing, about treatment, about isolation, the health department is an invaluable partner in accomplishing that. And again, not just with COVID. It would also apply if you have outbreaks of flu, of noro, or whatever the situation might be. Now, it goes without saying that training your staff on everything we've talked about in the last 50 minutes and more is key. This is, of course, part of the assisted living caregiver training in Arizona, but I think you also want to make sure you're reinforcing it regularly through your own in-service training. Don't just leave it to that initial training that they get through the state programs. It's also, I think, a good practice to spot check things. We developed this form that you see here, very, very simple little checklist we can use to actually go out on the floor and look to see that staff are doing all of this stuff correctly. One of the things we've found when we're dealing with COVID outbreaks is, other than isolating the resident, which is not always easy, especially in memory care, but other than isolating the resident, the most important step we have found in controlling COVID outbreaks is that staff are implementing all of these procedures correctly, that they're doing the basics. They're wearing their PPE correctly. They're performing their hand hygiene. They're doing all of these things the way that they've been trained. So we came up with this little checklist that a department head could go out on the floor, observe staff as they're working, and check to see that they're doing all these things correctly. And it's not meant to be punitive. It's not meant to be, oh, I'm going to get you in trouble and write you up. It's meant to be an opportunity for some quality control and also some quality improvement, so that if staff need to be coached up, need to have these things reinforced, it's an opportunity for us to do that. Feel like we covered a lot in 15 minutes. Hopefully this is some information that you can use to, like I said, really make sure you're focused on the basics. One of the things that always worries us when things are sort of the basics is it's easy to forget about them. It's easy to get much more concerned with all the other stuff like testing and all these things, when really it's these basics, the standard precautions, the transmission-based precautions, PPE. These are the things that are really going to help us to contain not just COVID, but all of these other potential infectious diseases we encounter from time to time. I appreciate you guys having me today. Certainly, if there's any questions, I can stick around, but otherwise, I will turn it back over to Karen.
Hi, everybody. Does anybody have any questions? I have to say, Mariah and I are sitting in here going, well, I didn't know that. Well, I forgot that I should be doing that. So I think it was very timely. I think it served as a great reminder, because I think we all kind of get sloppy because we're moving so fast. But okay, how do we get a copy of the hand hygiene checklist?
Can I send it to you, Karen?
Sure.
Okay. I will send it to you as soon as I jump off here.
Okay, we'll probably won't send it out, you guys, until either later today or Monday, depending on how crazy it gets here. Any other questions? Awesome. Josh, thank you so much. We appreciate you being here. I'm sure you heard that ALNA starting back up in Arizona, so we'll be in touch to chat with you about that.
Awesome.
And we started it in October last year, and then COVID hit, and that was that.
COVID ruined everything.
It did. It ruined all the fun. Okay, guys, thanks a lot. We'll see you on the next session. Josh, thank you so much.
Thanks, Karen.
Talk to y'all later. Well, or in 5 minutes.